this is Dr. Rajneesh Kapoor and Dr. Himanshu Dabral, Dr. Sushil is here, Dr. Shyam and full team is here, and Dr. Karan was also here, and then there are guys with the OCT and imaging also. So let's introduce our case. Can we have the slide, Sushil? Okay. Okay. So this is a patient who came to us yesterday, 55-year-old male patient, had episode of chest pain few days back, and there were ECG changes and troponins were mildly elevated. There is no other morbidity, but yes, the patient is quite obese. You know, he's almost slightly more than 100 kgs. Short and densely calcified LAD and diffuse disease in LAD, long segment, and then there is a high obtuse marginal coming from circumflex, which is also osteally diseased, which is also tight. So acute come back. Okay, so this is the ostium, there is a circumflex, and then left main. Okay, so this is.
Dr. Kapoor, Goran speaking.
Hi, Goran.
Thank you for selecting. Nice to see you again, and we look forward to the case. So in uncrossable lesion with really very severe calcified throughout the LAD, but also I'm afraid inside the left main. I think in my view, this is a case to prepare lesion with rota, post-dilate, and then stent all the way into the left main. So maybe, of course, we can postpone that decision regarding the proximal landing zone, but before, I think we should, this is uncrossable lesion at the level of bifurcation with rota, risk of occluding diagonal is relatively low. So my strategy would be rota, post-dilatation, repeat OCT, and then stenting.
I agree with that. So, yeah.
Manish?
Yeah, no, I totally agree with Goran here. This is a very heavily calcified mid-LAD. Orbital is a choice. I'd love to see what they did with Orbital, but my choice here would be front-cutting rotational atherectomy with a 1.5 burr.
With the panel, that it's a very densely calcified LAD and we require some calcium modification. Atherectomy device is the choice, and so I tell you what we did. Okay, so this is then, you know, we have to change it to a Viper wire. So we were planning a orbital. We were prepared for orbital. We didn't expect as a non-crossable lesion here. We thought we'll pass our Viper wire easily and do the orbital to the whole segment. And then obviously after the modification, we should be better off with the vessel and stent it. And this is a Viper wire there now. So after this, we started. We took.
Maybe we can let Dr. Kapoor work because.
Okay, so as I mentioned, you know, we tried getting the orbital down. Show the shots, but orbital, you know, nose cone was actually getting stuck at the same point. And then after a big patience, almost for 15-20 minutes, multiple passes, it was getting stuck at this point, but we maintained our patience, and this is all at 80,000 RPM. We kept the burr there, you know, look at this. So it crossed and jumped at one point, and this is almost after 10-12 minutes of burring.
Any regulation that precludes or do not preclude to do these type of procedures?
Okay, I'll start after this.
Sites that do not have a surgical backup.
But our guidelines say we shouldn't be doing rotational atherectomy without on-site surgery.
We should have a balloon movement much smoother, and that's what we are expecting.
More sophisticated care because we are not going to have enough. Can you tell us a little bit what you are doing and what are your plans now?
2.75.
2.75. Dr. Kapoor, can you hear us?
2.75. Yeah, we can hear you. Absolutely. I was engrossed in the steps. So we actually, after taking out the orbital wire, are we audible? Hello?
Yeah.
Okay.
You are audible, Rajneesh.
Okay, great. So we have taken the Viper wire out, exchanged it with the All-Star wire, and then you saw the movement of a balloon. It was much smoother. We have dilated the whole segment with 2O balloon, and I'm giving you a shot after that.
Balloon very fast. Do you stay in the open with the balloon more than a second?
So this is almost our second, third case of non-crossable with orbital. I mean, as dictum, it's rota, but somehow we got stranded in one more patient like this where it was non-crossable.
With the ablation again backwards as well.
10, 12. There are other advantages. There is no slow flow with orbital, I mean very less, and then TPI is not required. So slow flow with the rota is much more. If I think we would have kept the burr in LED for so long with the rota, definitely we would have a much better thinking with a non-crossable lesion. You know, you have to be very patient. I mean, keep moving the nose cone of orbital, you know, very slowly, gradually towards that non-crossable point. It is modifying the calcium in the vicinity very slowly. We can't be very fast as we do with the rota burr. So this mechanism is different. So we have to be very diligent and very patient while using this orbital. Okay, go AP cranial, please. AP cranial. This is there is calcium modification definitely which has happened. There are cracks visible. Show some cracks here.
Yeah, definitely a lot of cracks.
You look at this. Look at the 12 o'clock position and the 6 o'clock position, and move ahead. Come distal. Yeah, look. Yeah. So these are the cracks. I think we have modified the calcium in the vessel, and for the sake of it, I'm going to.
But you know, obviously, we have done our own studies where looked at the precise placement of a stent versus crossover. Obviously, crossover is recommended in
6, 8,
at least in our study.
10, 12, down. हाँ अभी ठीक हो जाएगा.
You did something offline, so what we are seeing is the OCT post-stenting and post-dilatation or just post-stenting?
No, this is a OCT prior to this stent at the LED ostium. We wanted to be sure whether left main distal is sound and healthy. So show the left main. This is left main distal, and it looked good to us. There is no big atheroma there. I mean some plaquing. That's it. And come towards the LED ostium now. So we are entering the LED ostium. Look at this, and that's where we decided let's this after stenting. So look at this, right at the ostium. This is our stent. Come back from left.
Can you make OCT bigger?
Yeah, please make it bigger, full screen. Okay. Yeah, no, come again from the left main. So yeah, so this is left main. This circumflex ostium. Come back. Come into the LED. So we are entering into the LED, and here is the stent. Okay, move. So this is all the stented segment in LED now. The area is 6.9, although we need to post dilate aggressively still. You know, we are going to dilate with
Dr. Kapoor, can we go to 3D bifurcation
3D bifurcation mode.
3D bifurcation.
Yeah, we are showing to you, Goran. Yeah, look at this.
This is definitely precise placement, right, Goran? What do you think?
This is super precise.
Okay.
I thought he would be back at least one stent strut into the left main, but actually he proved me wrong. You know, so.
Dr. Kapoor, congratulations. This is really masterpiece of work.
Thank you. Give me a post-dilating balloon, NC, first 3 and then 3.25. So
I can just congratulate to both Dr. Chandra and Kapoor. Excellent demonstration of how to apply modern technologies to prepare calcified lesions and perform stenting.
So
congratulations to both.
This is the last shot. Look at this. So where we started and how the vessel looks like. And although I think we are not having enough time, so this is the last angiographic shot. Still some post-dilatation required at the tightest point around diagonal. I've done post-dilatation with.
So, congratulations to both Dr. Chandra and Dr. Kapoor for the great cases and great demonstration.
Thank you.
Yeah, thank you, Rajneesh and Chandra. I would give the opportunity to Dr. Manish Parikh, who is the coronary track director, program director, to close this session. Thank you.
Yeah, no, so fantastic sessions. Again, very valuable. The way they were done, challenging cases, no one right way of doing it, but clearly plaque modification and imaging is here to stay. In the United States, we're only doing 28% imaging still, despite all the data. We're way behind the rest of the world, and hopefully with meetings like this, we're going to improve our image-based PCI moving forward. So really looking forward to that. So Dr. Kapoor, congratulations. Thanks, everyone.
Thank you.